Hi, everyone. I am so excited to see you all online today. Welcome to the Scleroderma Research Foundation's third annual Patient Forum, Collaborating for a Cure. I'm Susan Feniger, and I'm a board member here at the SRF. Like many of you, scleroderma has impacted my life in such a big way. In the 80s, my old college roommate and very close friend Sharon Monsky was diagnosed with scleroderma. So when she found this organization a few years later, of course, I joined to help advance a search for a cure. Over the years since then, I have seen incredible progress made in understanding and treating scleroderma. And I am so grateful to the Scleroderma Research Foundation and its supporters for being leaders in that progress. Within the last 10 years alone, the Scleroderma Research Foundation has launched major initiatives like Conquer, the first ever longitudinal patient registry in the United States. Most recently, we launched Conquest, a global platform clinical trial just for evaluating scleroderma treatments. But I have to say, it's people like you all. You are the reason we keep making these strides forward. Research is the key to ending scleroderma, and that is what Sharon always believed. Your collaboration is the key to moving research forward. Through your partnership, we can keep research at the center of everything we do at the Scleroderma Research Foundation. Together, we can find a cure. Thank you so much for all of your help.
Susan, thank you so much. To everyone joining today, welcome. My name is Luke Evnin, and I'm the chairman of the board of the Scleroderma Research Foundation, a role I've taken on for over 20 years. As both chairman and as someone who lives with scleroderma, I'm honored you chose to spend your time with us today at the third annual SRF Patient Forum, entitled Collaborating for a Cure. And I'll hope you join me in extending our gratitude to the scleroderma experts joining us today to share research updates, disease management strategies, and how you can participate in research. First, let me take a moment to introduce you to the Scleroderma Research Foundation. The SRF is a powerful, vibrant, and enduring pillar of the scleroderma research community. We recruit expert scientists and clinicians to serve on our distinguished scientific advisory board. We fund world-class investigators whose programs span from basic research through translational research and into clinical research as well. We're also the creator and sponsor of the nation's only multi-center longitudinal registry of scleroderma patients, and we do that in partnership with 17 scleroderma centers all across the country. At the Scleroderma Research Foundation, we're searching for answers all the way from cells to patients, all in search of ultimately the cure. I'm thrilled to share that we've taken unprecedented steps to accelerate getting new treatments to people living with scleroderma. We designed and launched Conquest, the first ever perpetual clinical trial platform for any rheumatologic disease. Conquest aims to speed the clinical development of novel medicines to treat scleroderma, with a particular focus in its first iteration on those scleroderma patients with interstitial lung disease. The platform has garnered strong support from Scleroderma Clinical Trials Consortium and entities all across the world. With that, Conquest could have reverberations not only across the global scleroderma community, but also the entire rare disease community and throughout rheumatologic disease. We'll cover more about platform clinical trials in a session later today. Conquest embodies the core of our mission. We are singularly focused on advancing research toward a cure. And this endeavor is only possible through partnership with you, and it relies on your generosity. We can't find a cure without you. The collective energy, inspiration, and generosity of our community drives us forward. So, thank you for collaborating with us. Together, we will end scleroderma. Thank you.
Hi, everyone. I'm David Knoller, and I'm a board member here at the Scleroderma Research Foundation. I joined the board of directors in 2015 because I live with scleroderma and I want to see this disease cured. I'm thrilled to see so many of you joining us. Before we begin our first session, I have a few notes to help you make the most of today. Today, we'll share 9 educational sessions. The sessions run back to back and start automatically, so you don't need to leave one to join the other. For this session and all sessions today, you can submit questions for the Q&A at any time through the panel on the left side of the screen. We'll select questions to be answered live and we'll follow up to as many other questions as we can. All right. Now, it's my pleasure to introduce the first session. But doctor, I don't want to take a medicine. Non-Pharmacological Management of Scleroderma, hosted by Dr. Ankoor Shah. Dr. Shah is an associate professor of medicine, rheumatology, and immunology at Duke University School of Medicine. He is originally from New Jersey, where he did his medical school training before coming to Duke for residency and fellowship training. He is the director of the Duke Scleroderma Center, one of the centers in the country focusing on this disease. His particular interest is in the use of cellular therapies, such as stem cell transplant for the treatment of scleroderma. Additionally, he serves on the section as the section chief for rheumatology at the Durham VA Medical Center. And now, please welcome Dr. Ankoor Shah.
Okay, well, thank you for the introduction. Again, my name is Ankoor Shah. I'm the director of the Duke Scleroderma Center. And my talk is entitled, But I Don't Want to Take a Medicine. And the focus is going to be on non-pharmacologic or non-medical management of systemic sclerosis. And like all talks I've probably ever given in my life, this talk is inspired by a patient, and I can think back to a very recent memory where I spent 20 plus minutes talking about the medications and pills that a patient could take for their Raynaud to help prevent their digital ulcers, other medications that they could take to help with their GI symptoms, their reflux, their heartburn, their constipation, and then separate medications that they potentially could take for their pain, medications that they could take for their fatigue, and medications they can take for sleep. At the end of talking about all those medications, the patient said to me, "But doctor, I don't want to take a medicine. Is there anything else I can do to help manage my symptoms?" And of course there are. And there has been actually emerging research and studies done on how patients can manage their own scleroderma. So the objectives of this talk and what we hope to get through is, again, to review the symptomatic management of systemic sclerosis and scleroderma, and I'll use those terms interchangeably, without medications. And specifically, we're going to focus on Raynaud's phenomenon, digital ulcers, GI symptoms, joint pain and contracture, and of course, fatigue. There are some aspects of scleroderma that we really cannot manage without medications. If you have lung disease, if you have pulmonary artery hypertension, if you have kidney disease, I don't think we have a good way to help you with your symptoms without medications, but there's a lot we can do for the other symptoms of scleroderma. So self-management of scleroderma. We don't have medications for all symptoms. I think everybody that has dealt with their scleroderma knows that. We don't have medications for all the symptoms. Doctors often focus on medications and forget about what patients can do outside of the clinic, as I did with my own patient. I want to make a plug also for a website and a program that was designed by researchers at the University of Michigan as well as the University of New Mexico, in part with the Scleroderma Foundation. And you can go on the internet and type in self-managed scleroderma, and it takes you to a website. And it goes through a series of modules that help you really manage your symptoms of scleroderma. And a lot of what I'm talking to, I actually learned from this website, and we're going to add a little bit more to it. But I really want everybody to go check this website out and see if it can help them with their symptoms. I really do feel that patients that learn how to self-manage their scleroderma, it can bring a sense of empowerment over the disease instead of the disease having power over the patient. So what can we do about skin tightening? Well, I will often send patients formally to occupational therapy. Occupational therapists are experts in dealing with fine motor function, and how to improve mobility and function, and improvement in ability for patients to do their activities of daily living through their day-to-day lives. They will often prescribe hand exercises, both passive, meaning ones that somebody will do to you, and active, meaning ones that you will do yourself. I'll show you some pictures on the next slide, but some of the exercises they have people do every day, even before their skin involvement of specific areas, is to push the hand flat, hold it down with the other hand, and hold it there for 5 to 6 seconds. Press on your proximal interphalanx joint or your knuckle with 3 points of contact to straighten the knuckle as best you can. Again, holding this for 5 to 6 seconds. Shove your fist into your palm to fold the fingers into your fist and increase the mobility there. Again, doing all of this for 5 to 6 seconds, even if there isn't skin involvement there, to help maintain your range of motion. I often tell patients to do orofacial exercises, and I put some examples of these down below. Both of these pictures were taken, again, from the website Self-Managed Scleroderma, and goes through a number of stretching exercises that patients can do every day to help maintain the movement of their mouth, improve their ability to do things like eat. I'll often tell my patients in clinic to do an exercise with a box of tongue depressors. So I'll have them take a box of tongue depressors and stack the tongue depressors in their mouth until it stretches the mouth to the point where it's a little uncomfortable. That provides a stretching exercise that the patients can do every day. But for me, it also provides a measurement. We can say, okay, I can fit one more tongue depressor in there, or you know what, my mouth is getting smaller and it's getting harder for me to put the same number of tongue depressors I would be able to do, say, a month or two ago. Again, this provides a helpful measurement. As mentioned on the previous slide, here are some of the examples of some of the exercises that you can do. Again, I have patients work with an occupational therapist if they're having symptoms of tightness, contractures in their hands, and they will go through some of these exercises. There are videos online that can show you how to do these exercises at home and how often to do them. The one I didn't mention previously in the bottom right corner is a stretching exercises that one can do for the thumb and the second finger. Again, holding these for 5 to 6 seconds, doing these several times a day. The opposite of this is folding the thumb into the palm, and again, that can help with range of motion of the thumb. So anybody with hand involvement can do these exercises on a day-to-day basis to improve mobility. One technique I wasn't so familiar, but actually has some studies that have shown improvement in patients with scleroderma, is something called manual lymphatic drainage. This is usually performed with a patient in a lying position, and often done by an occupational therapist with experience with manual lymphatic drainage. Starts with and ends with deep diaphragmatic breathing. The ineffective lymph nodes in the region of the body are treated first. You move from the center of the body to the distal parts, meaning the extremities, to drain affected areas using slow and rhythmic movements, gentle pressure, which is essential. And the one technique that, again, you can look up that's been associated with improvement in patients with scleroderma is something called the Vater technique, where different kinds of hand motions are used on the skin depending on the part of the body being treated. It includes edema movements in fibrotic areas, so this is helpful for patients with the diffuse cutaneous form of scleroderma, and different motions including the pump, the scoop, the stationary circle, rotary, and thumb circle. So it may be helpful to talk to your occupational therapist if they're familiar with this technique. For joint pain and contractures, again, those occupational therapy exercises can be helpful. I love having patients use paraffin waxes. I feel like it's been helpful for my patients both with scleroderma and simply with arthritis of the hands. Yes, even with scleroderma, patients can develop wear and tear osteoarthritis like everybody else does. To use the paraffin wax, and this is a kit you can buy online for $20 or $30. You spread your fingers apart, slowly put your hands in the wax, remove your hands gently, count to 5, then put your hands back in the wax, and you repeat this 5 times to create layers of wax over the hands. You can then cover your hands with plastic bags and then wrap them in a towel and wait 20 minutes. After removing towels, you remove the plastic bags and peel the wax from your hands, and that warmth can sit in and really help with mobility and pain in the joints. This can be a really effective and safe technique. However, I do caution any patients with open ulcers or digital ulcers to not do this. It could potentially make them worse and potentially hurt. Moving on to Raynaud's phenomenon, which is incredibly common in all patients with scleroderma. Again, up to 99% of patients with scleroderma will have Raynaud's. The first thing I always emphasize to all patients is to quit smoking. I will tell patients in clinic there is pretty much nothing I can do for your Raynaud's if you're still smoking. Decreasing caffeine and other stimulants can also help with Raynaud's. But there's a world of heated products that can be very helpful for anybody with Raynaud's. Heated gloves, and in fact, a recent study was presented at the National Rheumatology meeting that showed that heated gloves, when used correctly and used daily, can be as effective as conventional medications for some patients with Raynaud's. I discovered this when putting this talk together, that you can find heated keyboard pads and heated mouse pads. So when you're at work and you're in a cold environment, this can really help keep your Raynaud's from being a problem. One website that I send patients to on a frequent basis is the Raynauds.org webpage, which I've linked below. If you look, there's a little button that says Marketplace. You can click on that, and that takes you to a full page of products that are designed specifically for patients with Raynaud's. A lot of my patients have seen this before, but they'll discover new things that they've never tried before that ends up being very helpful. In addition to the Marketplace, the Raynaud's Association has a store for products for people with Raynaud's, including their mascot, which, if you haven't seen it, I'm wondering if anybody can guess what their mascot is. It's a blue-footed booby, and his name is Shivers, and you can buy him and bring him home. Digital ulcers are a common problem in patients with scleroderma. One of the ways to help prevent digital ulcers, reduce exposure to water. It may seem counterintuitive, but washing your hands frequently actually dries them out. I have patients moisturize their hands frequently through the day using lanolin-based moisturizers. I have them use Vaseline, particularly on those parts of the fingers that get cracked and chipped, particularly in the winter. Some of my patients will put Vaseline on their hands, put a glove over it, and let it just sit there overnight. For patients that have cracked fingers or maybe even small ulcers, neoprene thimbles are available online and can be very helpful for protecting it. I send my patients online to get these Silipos, these flexible bandages with a little silicone pad. They're called Silipos, and you can get a bunch of them. They can be used on the fingers, they can be used on the toes, and these can help protect ulcers from painful stimuli. Moving away from Raynaud's and ulcers, upper GI symptoms, gastroesophageal reflux disease, or GERD. Dry mouth is incredibly common in patients with scleroderma. That could be part of the disease. It could be secondary to medications. I have patients increase water with meals, use over-the-counter products like Biotine. Ensure that they're getting good oral hygiene and dental care to help protect their teeth. If patients can't moisturize their food or can't chew their food, it'll make it hard for food to get down their esophagus. There are very common food triggers for reflux: tomatoes, caffeine, acidic foods, fatty fried foods, even chocolate, which I hesitate to say, garlic, raw vegetables can all increase reflux and heartburn. Reducing carbonated drinks like beer and soda can help decrease bloating in the stomach. Quitting smoking, again, I put that in bold because if any of our patients smoke, again, it makes many of the symptoms very hard to treat. Waiting 3 hours after eating to lie down and sleeping at a 30-degree angle. Some of my patients will just prop their head up with pillows, and that will not work. In fact, putting the whole bed at 30 degrees by putting bricks or blocks under the head of the bed, or getting a full mattress wedge, there's one company called the Reflux Guard that markets one, can be very helpful for managing reflux symptoms. Some of my patients just use an upper half of the body sleeping wedge, and this is okay too. Constipation. A high fiber diet can sometimes help. We often recommend it. Stool softeners, which I suppose may fall under the category of medications, but at least they're over the counter, are the basic treatment of choice for constipation. And probiotics, again, I put a question mark there. There aren't a lot of studies done for probiotics. These are live microorganisms. But a small study of 10 patients with scleroderma found that they could reduce bloating. And again, the dosage that was used in the study is 10 billion colony-forming units per day. So some of my patients will try probiotics, and I don't think there is much harm. But of course, if it's not helping, I would recommend stopping. Diarrhea and fecal incontinence. Fecal incontinence can affect up to 10% of patients with scleroderma and can be a really hard thing to deal with on a day-to-day basis. Again, a high-fiber diet can be helpful for diarrhea and can improve stool bulking. I often will send my patients to pelvic floor physical therapy, which can help strengthen the anorectal muscles. Rectal tampons. This was something that was brought up to me by a patient. There's nothing special about rectal tampons. They're just tampons you use in the rectum. And it can help improve symptoms of fecal incontinence and allow patients to do things like go out to dinner and have fun with friends and family. One, again, medical therapy, although not particularly a medication that has been used, is sacral nerve stimulation, which I've placed right here, a picture of. Basically, an electronic lead is placed into the muscles that innervate the nerves that innervate the muscles around the anus and sphincter and can help improve strengthening these muscles. Again, there are very limited studies in scleroderma, and I've yet to find a colleague here at Duke anyway that has had any experience with this, but there is some experience elsewhere. Diet comes up all the time with patients. The anti-inflammatory diet, if you Google this, you will find many, many anti-inflammatory diets. And I put a question mark here because it really hasn't been studied in patients with scleroderma to show improvement. However, the anti-inflammatory diet generally comprises of deeply colored fruits and vegetables, fatty fish, ground flax seeds and walnuts, extra virgin olive oil. And certainly some patients of mine that have switched to an anti-inflammatory diet have noticed some improvement in symptoms. However, I always want to make sure I am not being too restrictive in patients' diets because 30% of patients with scleroderma are at risk for malnutrition. Poor nutrition and weight loss, and again, some of this is circular. These symptoms cause poor nutrition and weight loss, but it has been associated with an increased risk for pulmonary hypertension, heart failure, low protein levels, and skin tightening. A low FODMAP diet, which is something that is often recommended to patients with irritable bowel syndromes, and you can look up what a low FODMAP diet has been recommended to patients with scleroderma. However, studies of low FODMAP diets have not shown to actually benefit GI symptoms, so I think the jury is still out on that. Because food moves slowly through the gastrointestinal tract in many patients with scleroderma, more frequent meals, but smaller, basically grazing through the day every 3 to 4 hours can be helpful. Improving caloric intake with homemade smoothies, nutritional supplements such as Ensure or Boost, basically whatever tastes good for you, I do recommend. Exercise. So exercise is critically important in patients with all types of rheumatic disease, but particularly scleroderma. And certain exercise regimens have been studied. And in fact, one study in 2020 found an exercise program consisting of use of a stationary bicycle, bicep curls, as well as neck, arm, and hand stretching just 3 times a week was able to improve the walk distance, the hand grip strength, and the quality of life in patients with scleroderma. One form of exercise that I recommend because I personally do it and I personally enjoy it is yoga. Now, many of my patients have said to me, Doctor, I can't do yoga. I don't have the flexibility to do things like downward dog or any of these other movements that patients see people without scleroderma doing. Well, there is in fact an entire course and website designed to teach people with scleroderma about yoga. And I put the link here, but if you just Google yoga for scleroderma, you can find this website. It includes videos, a podcast for relaxation techniques, and actually live Zoom classes on Wednesday at 6 p.m. Eastern. So this can be incredibly helpful. Yoga hasn't been well studied in scleroderma, but again, my experience with patients that have been able to incorporate yoga have noticed improvement in their overall health, and I certainly recommend it. Supplements and herbals comes up all the time, and like many other things, they haven't been studied extensively in scleroderma, but there have been a few that I would talk about today. Ginkgo biloba has been studied in many small studies within scleroderma. There are mixed results, but at least one study demonstrated improvement in Raynaud symptoms. Evening primrose, which is another herbal supplement, again, mixed results in studies, but at least one study of 21 patients, which in scleroderma we consider a relatively big study, found improvement in Raynaud symptoms as well. But neither of these have been shown to help any of the other symptoms of scleroderma. Vitamin E, again, studies are limited to case reports of varying doses of 200 to 1200 units per day with a variable response, but some improvement in Raynaud's, calcinosis, and skin tightening. Vitamin D, which we recommend to basically all patients, hasn't really been shown to have a clear benefit in scleroderma symptoms. However, it has been observed that many patients are vitamin D deficient. So I recommend vitamin D to patients simply to help prevent their bone loss and osteoporosis. Fatigue. I think probably an hour-long talk about fatigue and scleroderma could be done, and there's a lot of different approaches to fatigue. Again, aerobic exercise of 30 to 40 minutes, 3 to 4 times a week, low impact, things like walking on a treadmill, biking if you can do this, swimming if you enjoy doing that, has been associated with improvement of fatigue. Sleep hygiene, getting TVs and screens out of the bedroom. Counseling, both face-to-face and telehealth counseling, has been helpful for fatigue. Group therapy, what many of you are doing right now. There's been a study looking at a 6-week, 1.5-hour group discussion about various topics of scleroderma, mental health, exercise, and nutrition, and that's been shown to improve fatigue in patients with scleroderma. Budgeting energy. Many people have different concepts and frameworks for how to budget energy during the week. I've heard of the spoon theory. I tell patients to create a to-do list with a due date. Rate each activity based on impact to others, what's a low impact to others, what's high impact to each other. Assess how realistically you can accomplish each task that week. You have good weeks and bad weeks. And then delegate if possible. That can be really helpful in budgeting your energy. There's a new study that's been published that looked at an app that's created by the University of Michigan called the Renew app. You can look at this on Android or iOS. You can download the apps. It allows you to set goals and track health behaviors and assigns patients to an online health coach. Again, use of the Renew app has been shown to improve fatigue and quality of life in patients. And finally, mood and depression. This is probably well tied to fatigue. Again, psychotherapy and referral to a psychologist is something that I do for many patients. Number of techniques have been used to improve mood and depression in patients with scleroderma, including cognitive and behavioral therapy, biofeedback, and coping skills. And one of the sort of coping skills that I sort of put at the corner there is sort of a framework for moving through how to think about your symptoms, your daily life, and things to do, and how to kind of use this framework to improve one's mood. Again, sleep hygiene is critically important. Whenever patients talk to me about mood and depression, we often talk about how to improve sleep, which can make a big impact, and even light exposure. This has been shown for mood and depression outside of scleroderma clearly, but getting daily sunshine can be helpful for improving mood. I've talked about a lot of things. I definitely want to hear from you all now, and how do you manage your scleroderma, and any questions that you may have.
Dr. Shah, thank you so much for that informative presentation. And hello to everyone joining us today. I'm Omar Baker, and I'm on the board of directors at the Scleroderma Research Foundation. I joined the board a little over a year ago because scleroderma has directly affected my family. My mother passed away from scleroderma complications, and my mother-in-law also lives with this disease today. This is why it means so much to me to be part of sharing scleroderma education. I'm excited to be part of today's first Q&A session with Dr. Shah. We've had quite a few questions submitted, and I'm going to start with one of our first questions from our listeners. Dr. Shah, we have a question that relates to painful digital ulcers that continue to come back in one of our listeners. So she's looking for some advice or counsel on what more she could do.
Well, thanks, Omar, for the question and moderating, and thanks to all of you for listening and being out there. Digital ulcers are one of the most challenging symptoms of scleroderma, and I think I talked a little bit about some of the things that you can do. Of course, prevention of digital ulcers is key. Prevention, stopping smoking, things, caffeine, things that cause the ulcers is critically important. However, once you get the ulcer, some of these preventative techniques don't really help all that much. So one of the key things I try to emphasize with ulcers is really keeping them moist. Washing your hands actually counterintuitively dries out your hands. So what I have patients do is keep the wound moist. You can use Vaseline. It doesn't have to be an antibiotic. In fact, those haven't really been shown to work all that well. A few times a day, you can soak the finger in warm water for about 5 minutes, and that can help moisten the area. The key is to keep it from drying out. I use occlusive dressings. One of the most helpful dressings is something called Duoderm, which can be cut around. The digital tip is a really hard place to put a dressing. I use things like Medi Honey, which can be a liquid dressing. It can also be really helpful. So the key is to cover it, keep it moist. If there is a scab that forms over there, that can actually impact healing. We often will send our patients to a wound clinic or a plastic surgeon to help unroof that area of scar tissue, and that'll allow the ulcer underneath it to heal a little bit more. A wound clinic can be a really important resource for many of our patients.
Excellent. Thank you so much, Dr. Shah. Our next question is a simple but extremely important one. How would one go about finding an occupational therapist that's familiar with scleroderma therapies?
Also challenging, and depends on where you are in the country. There may be more occupational therapists that have experience with scleroderma than others. I think one of the keys is talking to your occupational therapist, seeing how much experience they've had with scleroderma, but you don't have to necessarily have experience with the disease to learn and to be taught how to stretch the hand, how to use assistive devices, the same devices that are used for people with advanced arthritis, which is of course much more common than scleroderma, can also be very helpful for patients with scleroderma itself. So there may be occupational therapists out there that are very uncomfortable with the disease, and in which case, yes, finding another one may be helpful. And then, of course, I did post some links to some websites that can actually teach you how to do a number of these exercises at home by yourself. And in fact, there are YouTube channels that teach you how to do some of these exercises at home. That's always a helpful adjunct to what can be done formally with an occupational therapist.
Fantastic. Thank you. The next question is on the topic of fecal incontinence and a patient who has frequent unforeseen accidents. Any suggestions for this?
Sure. So fecal incontinence, well, it can be an uncomfortable topic to talk about with your doctor. Is an important one too. About 10 to 15% of patients will have some degree of fecal incontinence, sometimes severe. It can limit your ability to go outside, enjoy your quality of life. I learned from a patient when other things like increasing your fiber, changing your diet don't work. One of the things that she's used when she goes out is a tampon, a rectal tampon. They actually make these for patients with incontinence. You can find these online. You can find them in medical supplies, but she just uses a regular tampon. It acts as an absorbent, And it certainly allows her to carry on with many activities of her daily life that she was unable to do beforehand. It's a pretty simple, practical approach that can really help with some of those symptoms.
Great, thank you. The next question is regarding poor appetite and food intake, and a patient who's concerned that they're not getting enough protein in their diet. I'd love for you to address that.
Yeah, so and it can be very hard to get protein and other nutrients, vitamins in your diet if your gut isn't absorbing. And frankly, if food just isn't appetizing to you. When patients' guts don't move, they get full very quickly. So the idea of eating, particularly eating a lot, becomes really challenging. I've talked a little bit in the talk about trying to make protein shakes, and sometimes the ones that are commercially available are either expensive or they don't taste good. So making things at home that have increased protein, such as with peanut butter or even protein powder, that can be made into a smoothie that you can take throughout the day, have a little bit every couple of hours. And that way you can actually quantify the amount of protein you're getting. You can keep a diary of how much you're eating. And that can be one way to get around sort of the decrease in appetite, the decrease in ability to eat more, is by adding supplemental protein to things like shakes that taste good.
Great, and you alluded to it in your wonderful presentation, but we have a question that goes to treatment modalities for Raynaud's. Specifically, do heated gloves work, and other non-medicinal treatments? I'd love for you to speak about that a bit more.
Yeah, I urge everybody to take a look at the Raynauds.org webpage, and just as a framework for all of the things that are out there. I can talk about gloves specifically. So battery-powered heated gloves have been shown, at least in a small study of patients during the winter, to be as effective as conventional medications like amlodipine. Now, it doesn't replace medications for many patients, but in some, it can be as effective. So I have patients go out and get a pair, keep hot hands in their purse or in their glove compartment of their car. So even if they're going into a cold environment like a grocery store, something that they're not expecting, they can have their hands warm going into that. They make a battery-powered heater that you can plug into a cell phone charger that you can dial up or down the heat. That can last several hours. And again, many of my patients will carry this with them. I've done something in our clinic that I've tried to do, and that's I've asked them to turn the heat up in our clinic. So you can ask your doctors or places where you're going to go if they can increase the heat. These are little things that can be done to decrease the rate of flares in the places where you go.
Great, very helpful. The next question is on exercise. You mentioned, obviously, the tremendous importance of exercise. We have a patient with limited mobility, joint pain, and friction rubs. But the patient's wondering how can they balance that pain with good exercises?
Yeah, I certainly have a lot of patients that have intense contractures, particularly in the early stages of the disease, that really make it hard to do any sort of exercise. I talked a little bit about yoga, which can be helpful, but again, there are some patients where that is really, really challenging to do. And I think that that's where seeing an occupational and physical therapist to get through some range of motion exercises to start that process and have someone that is trained that can help sort of guide you through some of these exercises. Keeping moving, walking as much as possible. But of course, pain management can be a really important part of that. There are a number of medications out there, and I know this is a non-medication talk, that can be helpful for managing pain, even over-the-counter pain management that can be done prior to doing exercises. I really like the paraffin wax bath. Heating up the joints can loosen them just a little bit enough that you can get a little bit more exercise, a little bit more movement. And remember, it's a very slow process. It's not something that you're going to be able to do things you aren't able to do in a day. It has to be a really slow, gradual, and graded approach to increasing exercise in your day-to-day life.
Great. And you touched on supplements. We have a question on, which supplements are beneficial, and are there supplements or over-the-counter remedies that should be avoided?
Yeah, the challenge with supplements is that they're rarely studied to any degree that conventional medication is, for better or for worse. I have not come across really supplements that have been problematic for my patients. So there's really nothing that I would say you absolutely must avoid. Certainly, there are some patients where they've found that things like probiotics were unhelpful for them or made their diarrhea worse. Of course, that's something that we want to avoid, but those are things that can be done on a case-by-case basis. Things like turmeric have been helpful for patients that have joint pain. I mentioned a few others, like primrose can be helpful for patients with Raynaud symptoms. And really, the way I approach supplements is to try something, not try so many at one time. Try one or two and give it a good 6 to 8 weeks. And if you notice an improvement, great. If not, then we would just stop it. But there really aren't any known interactions between supplements that we would typically use and conventional drugs that we use for scleroderma. So I encourage it. If there's a symptom that you think may be helpful that another patient or a friend used, it's fine to try.
Great. And we have a question on the importance of fiber and nutrients. But it was mentioned that raw vegetables can contribute to worsening reflux. So how does a patient ensure they're getting enough fiber and good nutrients and balance that if they have reflux due to their disease?
Yeah, so tailoring your diet to your symptoms is critically important. I have patients see also a nutritionist from time to time that can help work through, putting together a diary. This is what I've eaten through the week or the last 2 weeks, and working with the nutritionist to maybe increase certain things and decrease other things to help improve the amount of vitamins that you're receiving in your day-to-day diet, the amount of calories. And again, I worry far more about weight loss than weight gain in my patients. That can be a helpful asset if there's a nutritionist. And again, they don't have to be an expert in scleroderma. They can go through your daily nutrition and see if you're receiving the adequate amount. Things like fiber, we do emphasize that can be helpful for stool bulking. So patients that both have constipation and diarrhea, it can be helpful. Raw vegetables, though, can be tough. Sometimes with irritable bowel syndrome, we recommend something like a low FODMAP diet. Raw vegetables can sometimes increase symptoms of gas and bloating. So again, on a case-by-case basis, you may have to avoid that, but then cooked vegetables may be totally appropriate, and you may get as many of the nutrients that you need with cooked vegetables.
Excellent. Thank you. We have time for one more question, and it relates to any self-management tools or remedies for itchiness of the skin.
Yes. So, itchiness often comes down to dryness. And so that's when this sounds like a broken record, but keeping your skin moist can be really helpful. So for example, I'll have people use a good cream-based, something that comes in a tub that you have to open the top as opposed to a pump, and really cover themselves after every time they take a shower or a bath, and cover themselves in a thick emollient cream. For the hands, if there's a lot of itching, we'll use even Vaseline overnight, dipping the hands in there, putting a glove over that, and that can help with itching as well. Over-the-counter antihistamines, again, which sort of fall into the medications category, can also be very helpful, and we'll often use those in addition to things like creams and lotions.
Well, Dr. Shah, thank you so much. We'll pause here as that's all we have time for today. For those watching, if you asked a question that we haven't answered, we apologize, but the SRF staff will follow up directly with you by email. Thank you all for joining us, and I hope you enjoy the next session. That's all we have time for right now. Dr. Shah, thank you again for spending this time with us. To everyone joining us, don't go anywhere. We'll have a quick evaluation popping up on the screen now, and the next session will appear on your screen shortly. Thank you very much, and we hope you enjoy the entirety of its session.